Thank you very much. Originally, as some of you may have seen the program, this talk was going to be given by Professor Alastair Campbell, who's a good friend of the Bioethics Center and a person from whom we've learned a lot. I have great respect for him. Unfortunately, due to unforeseen circumstances, he's unable to make it, and that's why the task fell upon me. Professor Campbell is a very eminent ethicist with a background in theology as well as philosophy. And I thought I might take a slightly different, if not a pragmatic approach towards this topic. What is the duty of disclosure? I want to begin by understanding how does this duty arise in the context of our relationship with patients. I then want to find out and explain what is it that we need to disclose. And I might briefly touch on the scope and dimension of this duty, but I know the eminent James Badenoch will be touching this because there are standards to which we will be held accountable for disclosure of information. And I want to discuss this in the context of the 4 pillars that define the understanding of modern biomedical ethics. That's autonomy, being good to our patients, putting their interest above us, doing no harm, and being fair. What is autonomy? Autonomy enables patients and people to select a path of self-determination. And it is information that we provide regarding their condition, their disease, their progress, their outcomes, that helps them make reasonable and informed choices. It is important that we be good. In fact, it is necessary that we be good to patients. A beneficent doctor is one who shares good information. We have affirmed our obligation to be good to patients without disclosing the relevant information that's necessary. Patients will not be able to make those informed choices and will not be able to select a path that helps them in their own good. Doing no harm sounds so intuitive. We should not do harm. But harm as a result of medical intervention is rife in the literature ever since we started practicing as doctors. We have an ethical obligation not to harm patients. But we can also harm patients if we do not disclose the information that may help them protect themselves. So disclosure is very important so that we do not do harm to patients. As part of our duty, we also have to be fair. Distribution of resources on a fair basis also demands the proper disclosure of information. We have professed to provide services to patients that we should provide. Without disclosing the proper information, we cannot be just in our delivery of services. Justice also means a right to continuity of care and non-abandonment. And you may be surprised patients feel if you haven't given them the information. And it sounds quite simple, but it is. If you see it from the perspective of a patient, you operate on a patient and suddenly he finds that you're not there, you've gone on leave, you haven't told him. And that's also failure to disclose and unfair to patients. The duty of disclosure has very strong ethical foundations in our fiduciary responsibility. A fiduciary duty is one where there is trust. Because we have specialized knowledge and skills, patients trust us. Typically, this was a common law. Fiduciary duties have a very strong common law basis. And one of the important requirements of a fiduciary is trust, loyalty, having the veracity of information, and the capacity to disclose it in a truthful manner. There are very strong legal precedents that support the fiduciary responsibility and duty in the context of medical application. And there are some classic cases that, if you're interested, you might want to look at. So departing a bit from the philosophical approach, I want to present a few concepts. On the one hand, when one has full compliance to one's fiduciary responsibility of duty of disclosure, you may have, on the other hand, a failure to comply, which, in the context of the law, is a remediable failure. And that's under very well-established principles. And somewhere in the middle, therefore, lies much of medical malpractice. And much of medical malpractice really is nothing but a failure of disclosure of information, which is often termed the disclosure gap. And I may add a little bit to this concept by conceptualizing a healthcare encounter. Typically in a healthcare encounter or a clinical encounter, what we are doing is not only diagnosis, but really we are finding out information about a patient's medical risk. Now, this is an interesting concept that's recently been talked about. So we identify the medical risks on the basis of history, on information, tests, diagnostic interventions, and then we proceed to manage that risk. How do we manage that risk? We exist in an environment that allows us to practice. We train ourselves as doctors. We continue credentializing. We deliver therapy. We have expected outcomes. And we manage the risk. Then we have care and follow-up to make sure that the risk doesn't manifest itself once again. We must have continuity of care. We must have the right personnel. We must have the right setup. We must work in an environment that we are allowed to work unrestricted. And we must continue in our quest for professional knowledge so that we can tackle emerging new diseases and new informations. There are 2 points in time when we make disclosure. Actually, we make disclosure continuously. But first is ex ante, before we intervene. That's right up in the first encounter. And the second is after we've done some intervention and we expect something. And for example, we operated and we expect something, and then we disclose things that have happened. A very interesting concept that's been evoked is the concept of the emergent medical risk, or an EMR. An emergent medical risk may arise when something that was not existing before, you didn't identify, but becomes manifest later. That risk may not actually be a health problem, but it may be a change in the environment. It could be the change, new information regarding a disease that has come up that alerts you to something new may have or could or likely to happen. This is an emergent medical risk, and therefore any significant and material change in the major components necessary for health is considered to be an emergent medical risk, or an EMR. And if you have this concept, it becomes quite easy to understand how disclosure stays with us, not only during the doctor-patient relationship, but perhaps even beyond it. And this is the fact that I want to discuss and elaborate a little bit. Disclosure about medical condition is quite intuitive. People often identify, oh, I can understand about a medical condition, what needs to be disclosed. We have diagnoses, we have available treatments that we need to share with our patients. We must explain to them the risks and benefits and expected outcomes. And this is very much part of informed consent, which I'm not going to elaborate because the next speaker is going to do that. There's also the concept of relevancy. We have to disclose what is relevant from a medical point of view. And there's also the concept of materiality. We are expected to disclose small risk of severe complications. The experience of doctors is also important. Are there financial incentives that the doctor may have in the treatment of a patient? Recently, what are the rates of successes? What are the complications rate? Even that, the courts have said, may be a requirement in some instances. And also, the diseases and addictions that doctors have themselves may play a role in a patient's ability to make choices, and therefore, that's something that needs to be disclosed. Disclosure about medical setup is important, because again, if you conceptualize this as an emergent medical risk, maybe you have a hospital that suddenly does not have an MRI. It's not functioning. Patients have a right to know. And therefore, some of the things that have been discussed are care rationing policies. Good example, an MRI is not covered for back pain. New drugs are not available in the hospital. There are HMO or insurance-driven guidelines, and one must remember these are organizations that have incentives for their own benefit, not necessarily only for patients' benefit. So these are examples where we need to disclose this information to patients so that they understand. Is a setup adequate in terms of the facility of care? Are manpower needs satisfied? Are personnel trained and credentialed? Do we have equipment that is available for resuscitation? And some of you may be familiar with some cases in Hong Kong where resuscitation equipment was simply not available. Even the ambulance couldn't reach the doctor's office. This is something that patients need to know beforehand. You'd be surprised, Ottawa ankle rules, for example, whether to take an X-ray or not, there is a failure rate. Patients need to know whether I'm going to be selected on the basis of my clinical symptoms or there's a guideline that drives policy in a particular institution. Darling versus Charleston, the case actually imposes liability on the institution for poor trained personnel who were entrusted with the care of an orthopedic patient, and the person was not really trained or credentialized to do orthopedic procedures. So institutions are also liable, but we need to disclose that emergent medical risk. So coming to the concept of EMR, new information regarding disease that becomes apparent and manifest, new tests that might be relevant that you did not have access to before, information regarding drugs and prior or previous interventions that now becomes important, test results that are discovered after the last clinical encounter, reinterpretation of results, unexpected or unanticipated outcomes. And the last one is quite apparent and quite easy, although that's one of the biggest sources of non-disclosure to patients. I want to give you one example of these names have been hidden. The case is slightly modified because there are people here who probably identify with these cases. Alice was 46. She had a gynae checkup prior to conception. It was suddenly discovered she had stage 1 ovarian carcinoma. She had successful treatment, chemotherapy. Her father had colonic carcinoma. Now it then became apparent that the history of ovarian, breast, and colon carcinoma was a very strong predictor of developing cancer in siblings, and it's associated with a BRCA1 and 2 mutation amongst others. And the BRCA test is now, it was very expensive those days. Now it's quite possible, quite easy. Her sister Kathy was also having routine gynecological checkups, but was never counseled or informed about the risk based on her sister's information. And she was recently discovered to have stage 3B ovarian carcinoma. And I think there has been an ethical breach of duty because there's failure to disclose material and significant information which could have resulted in better outcomes for her sister. There are plenty of examples of drug recalls and device failures, silicone breast implants, a huge amount of orthopedic device failures, and the students are too young to remember thalidomide, but recently Vioxx, the COX-2 inhibitor. It's quite... Another interesting concept is the latency. Latency of disclosure. In Israel in 1950s, migrants from Asia and North Africa were radiated for tinea capitis or ringworm. A high risk of radiation-induced head and neck tumors was subsequently recognized. And in 2006, a physician was held liable for failure to inform his patient who said he could have had regular MRI checkups of the head and neck if he was informed of the risk. And that's a very interesting concept that the case brings about. So the duty exists beyond the termination of the doctor-patient relationship. Whether it's enforceable is another matter, but it exists beyond the concept. And out of this comes the duty to warn, the duty to report, the duty to contact, and the duty to inform, all based on new information that then becomes apparent, results in the manifestation or the potential manifestation of a risk, or the EMR, as it's called. And there are plenty of cases in literature to refer to. I want to conclude by saying that my clinical practice involves a lot of complex information sharing. And here's a lady who's come to the end of a road, and I'm going to discuss it at the last session. It's extremely important we must disclose every possible bit of information that helps patients make and choose and come to very, very difficult decisions. And that's the nature of my practice. So I want to conclude, ladies and gentlemen, that the duty of disclosure has very strong deontological and teleological ethical basis. The ambit of disclosure is broad, and its implications are much wider than we are accustomed to think. I think increasingly the law applies a patient-centered approach where failure is actionable to tort, and I'm waiting to hear from the distinguished speaker later on. But I want to make a plea, in fact, that's the whole purpose of the workshop, that we must transform our way of thinking so that our actions are ethically based and not driven by any external agent. And with that, I thank you all for your kind attention. Thank you very much.